Hi, my name is Jacqueline Garcia. I'm an adult leukemia clinical investigator at the Dana-Farber Cancer Institute in Boston, Massachusetts. And I'm delighted to present an update from our clinical study that was presented in Abstract 190 at the ASH 2020 meeting. On behalf of my co-investigators, I had the opportunity to present our investigator-initiated phase 1 clinical trial, evaluating the safety and preliminary efficacy of adding venetoclax to reduce intensity conditioning chemotherapy prior to allogeneic stem cell transplantation in patients with high-risk myeloid malignancies. We know that patients that undergo transplantation are at risk for disease relapse. And unfortunately, in patients that receive reduced intensity conditioning strategies, the cumulative incidence of relapse can be upwards of 50%. But as that remains the only curative modality available, there is a lot of emphasis on how we could improve strategies either at the time of conditioning or at the post-transplant setting in order to reduce risk of relapse for these vulnerable patients. We've been able to see preclinically and now clinically that the oral BCL2 selective inhibitor venetoclax can prime myeloblasts for apoptotic induction, in particular when it's combined with chemotherapy. We've learned this in the MDS and AML setting when venetoclax is combined with hypomethylating agent therapy or with cytarabine in the AML upfront setting. And with this preclinical data and now clinical data demonstrating that venetoclax is a powerful apoptotic inducing agent when partnered appropriately with good chemotherapy, we proposed whether or not venetoclax could prime residual chemo-resistant myeloblasts that might be persistent at the time of transplantation in patients with higher risk disease who are recommended to undergo reduced intensity conditioning chemotherapy. We asked whether or not we could add venetoclax to our standard reduced intensity conditioning chemotherapy backbone, and whether or not we could do this without increasing transplant toxicity. And so this is a phase 1 dose escalation and expansion study assessing the safety of this combination therapy. The primary objective was to evaluate a dose and schedule of venetoclax to determine the safety profile and recommended phase 2 dose. Our secondary objectives were to evaluate the preliminary efficacy, remission duration, survival, and incidence of acute and chronic graft versus host disease. Our DLT window was from the first dose of venetoclax until day plus 28 post-transplant, with DLT defined as any treatment-related death, failure to engraft, grade 4 TLS, and grade 3 or higher VOD. With this 3+3 design, what we did was we took our standard reduced intensity conditioning strategy, which at our institution involves the use of fludarabine plus busulfan. We nickname it FluBu2. Here, fludarabine is dosed at 30 mg per meter squared, typically days -5 through days -2. Busulfan is given at 0.8 mg per kg twice daily, days -5 to day -2. And what we did was we added on venetoclax with the attempt to maximize the overlap of these treatments when possible. So in 3 dose levels, we steadily increased venetoclax from 200 milligrams up to 400 milligrams, starting at day -8, with it ending on day -2. And we were able to accrue to all 3 dose levels. The key inclusion criteria for this clinical trial that we had included adults, those with high risk MDS, AML, or MDS-MPN. Patients had to have an 8 of 8 HLA matched related or unrelated donor, an ECOG performance score of 0 through 2. Prior venetoclax therapy was allowed. Patients that were excluded included those that had greater than 5% blasts if they had AML, or greater than 10% blasts if they had MDS or MDS-MPN overlap. And patients that were in particular excluded were those that were recommended to get a myeloablative conditioning strategy. So here at ASH, we presented the data from the dose escalation and completed dose expansion cohorts, and this included 22 patients. The median age was 64. About half the patients had an ECOG performance status of 2. Half also had a diagnosis of MDS. 40% had a diagnosis of AML. Only 3 of the 22 patients had prior venetoclax exposure, and this correlates based on the timing of the drug approval for frontline AML. About 55% had a TP53 mutated disease as study entry, and half the patients had a complete remission at time of transplantation. We also found that patients, about 86% of patients on study had a pathogenic mutation detected at the time of transplantation. So overall, this was a high-risk patient population. It was a sick population as well, based on the ECOG performance status that I mentioned. But what was also notable is that 55% of patients had a HCT-CI score of 4 or higher. And so for this mixed population of high-risk MDS, we assessed the safety of venetoclax with flubu-2. And what we were encouraged by was that the toxicity profile looked to be comparable to what we would historically, what we would expect based on historical data with fludarabine busulfan in terms of non-hematologic toxicity. There were no dose-limiting toxicity events. We did have 1 death in the first 100 days due to a GVHD complication. We found that the incidence of acute and chronic GVHD looked to be as expected with fludarabine busulfan, with the 1-year grade 2 to grade 3 acute GVHD event of 23%. Most events were acute in grade 1 and reversible. And the 1-year rate of moderate and severe chronic GVHD at 33%. We were very encouraged by the lack of impairment on engraftment. That was our biggest concern. And what we found was the median time to neutrophil recovery was 15 days. The median time to platelet recovery was 14 days. When we looked at chimerism at day 28, we were also encouraged by the granulocyte, leukocyte, and T cell chimerism, which reflects what would be expected of fludarabine busulfan and lack of impairment by the addition of venetoclax. The estimated overall progression-free survival for a phase 1 study, again, this is a safety study, but we were able to get preliminary efficacy, and we were encouraged by what we saw at a median follow-up time of 12 months. Median overall survival was not reached among survivors. The median progression-free survival was 12.2 months. The 1-year estimated overall survival was 72%, and the 1-year progression-free survival was 55%. When we took a look at what was happening to the patients that did not do as well, the cumulative incidence of non-relapse mortality was 4.5% and so low, which was encouraging. And the 1-year cumulative incidence of relapse was 40%. This was not a randomized study, and it was a mixed population, but patients were overall higher risk. When we think historically of what these patients might have done, we know that the cumulative incidence of relapse historically for this patient population is at least 50%. And for those with mutations in TP53, the cumulative incidence of relapse is even higher. And so this was encouraging, though we have more work to do. Of the patients at relapse, this included 9 of 22 patients as of the state. So of these 9 patients, we just took a closer look at, well, who were these patients that were relapsing, and why might that have been the case? Well, 7 of the 9 patients did have a TP53 mutation prior to transplant, but very fortunately, 3 of the 9 were salvageable and were able to achieve a second remission, either by tapering immunosuppressive therapy or with chemotherapy plus donor lymphocyte infusion. And so, although we weren't able to rescue everybody, we did still have relapse cases that need to be addressed, and encouraged us to further improve upon our therapy. When we took a look at the paired NGS data using a clinical-based assay at the pre-transplant and day plus 100 time points, we were highly encouraged to see that most patients on study were able to clear their mutational burden. For those patients that had persistent mutational burden at day 100, all except for 1 represented patients that went on to relapse. And so overall, we were able to determine that venetoclax could be given at a dose of 400 milligrams daily for 7 doses when added to fludarabine busulfan, reduced intensity conditioning chemotherapy. We found that venetoclax did not impair engraftment or induce excessive GVHD. We did see in a phase 1 setting that was non-randomized that there was encouraging survival and reduction relapse for a high-risk mixed population. This trial was amended to allow for a post-transplant maintenance therapy, and this is being assessed in a separate arm. after patients receive venetoclax plus conditioning chemotherapy at the MTD that we have established.